Good afternoon, everybody.
Good afternoon.
Great, amazing. So, we would like to welcome you all to our third annual Black Maternal Health Conference, which is thrown and organized by the Greater New York City chapter of the Black Nursing Association. The Greater New York City Black Nursing Association was founded in 2017 with a vision to become a voice of reasoning, a voice of advocacy, and a voice of change for the Black communities throughout New York City and their surrounding boroughs. We started off small. Since then, we have grown to become the second largest chapter under the National Black Nursing Association, which is celebrating 51 years of age this year. So thank you, a big congratulations to everybody that's a member. So the Black Maternal Health Conference specifically was birthed out of the idea that we needed to do something to protect our Black women and our Black families during maternity. For just about everybody else, giving birth is a very glorious time. For a Black woman, unfortunately, giving birth is a time where they are 3 to 4 times more likely to lose their life compared to their white counterparts. So we decided as a chapter, who was supposed to be a voice of reasoning, advocacy, and change in our community, that this was something that we needed to do. So we advocate for it. We do this conference and other things locally, and then we also advocate and make sure that we do this change nationally as well. So my name is Dr. Julius Johnson. I have the pleasure of serving as the president of the Greater New York City chapter of the Black Nursing Association. I am blessed to be one of the members of the Black Maternal Health Conference. I definitely want to thank Long Island University, Brooklyn, as well as our deans. She's not here, but she'll be joining us virtually eventually. Dr. Peggy Talia for allowing us to use this space. This is actually the second time LIU Brooklyn has allowed us to use the space, so I definitely wanted to note that. The event is also co-sponsored by the National Institute of Health's All of Us research project, which aims to be the largest research study that they've ever done over a long span of 10 years, which really aims to do precision medicine. And by precision medicine, we're talking about making individual changes for people and being able to tailor medicine to people on an individual level and not just say it's a one-size-fits-all. I will go more in depth into All of Us, but you'll see some things circle around. So if you did not sign in / do the pre-survey, we will send a barcode around. All you do is open up your phone's camera app, and the camera will bring up the website for you. Easy enough? If you can't for any reason, I will send you the direct link to do that as well, okay? All right, I want to, because this is probably going to be the last time you hear me speak until the end, right? Because I believe as a man, it's just my job to say we have an issue and then put the people in front of you that can really speak to the issue, which is all these amazing women that's on the committee with me, right? Or I should say I'm on the committee with them. So I'm going to introduce our amazing committee. We have, and we have a very strong team, our co-chairs, Tanya Moore Murray, as well as, and I can say this now, because she did finish her doctorate, Dr. Kelly Floyd. We have Tanisha Thomas. Thank you, Sha. We have Elizabeth Hazelwood. We also have Emily Hazelwood. We have Kayla Preston. That is a big deal for us, giving babies and we're being a Black Maternal Health Committee.
Yes.
We also have, she's not here because she recently gave birth, Stacy Antwi. We have Naomi Gibson, Jarlene Barber, Mona Francois, I don't know if you're yet. Dr. Alicia Bryan, Dr. Camilla Barnes, Dr. Selena Gillis, Daphne Lysias, and Samel Arlen. All right. With that said, I'm gonna do what I do best and get off the stage from in front of you all. And I'm going to introduce the two people that are going to be our hosts for this Black Maternal Health event. We have Tanisha Thomas and Naomi Gibson. Oh, it's fine. They're seeing.
And Jay, can we unmute ourselves? They said they can't hear us.
Oh, I mean, there you go. Sorry.
It's okay. There you go. Good afternoon.
Good afternoon, everyone. Can you guys hear me clearly? Yes. Okay, great. So Naomi and I are just going to go through a presentation to give background information and just to set the tone for today's conference and help you guys keep in mind any questions that you may have. Okay, so just a rundown on the statistics or the stats that we have. As you can see, amongst the races, blacks had the highest pregnancy-associated and related deaths. Brooklyn was the highest amongst the boroughs. There was 3 prevalency rates of death resides the largest amounts of black communities, which was the Brooklyn, Bronx, and Queens boroughs. Top causes of pregnancy, associated deaths, embolism, cardiovascular, hemorrhage, and infection. Embolism making up 25%, cardiovascular also making up 25%, hemorrhage making up 15%, and infection making up 10%. So embolism is pretty much like delayed recognition by patients in healthcare is the issue why embolism isn't, well, it's the reason why embolism is an issue. Pericardiomyopathy within 5 to 9 months of postpartum, heart failure, and high blood pressure are the causes of cardiovascular. Sepsis or poor patient management is linked to the infection, and underestimation and failure to recognize the signs and symptoms leads to delayed response and recognition when hemorrhage is involved. The 10 states with the highest maternal mortality, we have Louisiana at the top with 58.1 per 100K, and New York is number 10 with 19.2 per 100K. And this is just giving us a ratio of the countries, US being number 1. The stats for the United States is 17.5K deaths per 100,000 live births. As I said, that was also number 1, and Canada and France falls second, United Kingdom falls third. The 2 most common issues amongst black women pre- and postpartum is preeclampsia and postpartum hemorrhage. Preeclampsia is pregnant or postpartum patients who have high blood pressure higher than or equal to 140/90. The risk factors are age, less than 20 and older than 35. First pregnancy, twin pregnancies included, history of diabetes, high blood pressure, obesity, and kidney disease, chronic stress, and family history. Signs and symptoms to look out for, high blood pressure as mentioned before with a pressure of 140 or over 90 or greater, blurry vision, upper stomach pain, weight gain and swelling, headaches that do not go away even when medication is taken. For postpartum hemorrhage, this is considered an emergency. It's excessive bleeding during and after childbirth. So it takes place during childbirth or within the first 24 hours after birth, even when returning home. Blood loss can happen suddenly and can have tragic effects, such as loss of the uterus or death. Signs and symptoms to look out for postpartum hemorrhage will be feeling lightheaded or dizzy, passing clots that are bigger than the size of a quarter, soaking a sanitary pad within 15 minutes or multiple ones before an hour, and frequent need to change pads. So I'm going to pass on the rest of the presentation to Naomi.
Thanks. Sorry. So a lot of what the data has shown is that there's more than enough maternal health inequities, not only in New York State, but throughout the country. Most of this is caused through the stress of racism and implicit bias within our communities of color and disinvestment in our communities as well. This exactly is the root cause, to be quite honest. There have been a lot of movements locally that have helped to increase our public awareness as well as spread it through New York mass media. So how can we help? We have a lot of self-advocacy. You should know your rights in New York State, and you should know the resources that are available to you. Self-advocacy. Speaking up for yourself is the #1 way to be aware. Asking questions like knowing your own fears, knowing who to address when you have those fears, your rights as a patient in the state. Specifically to the side, this picture, I don't know how good it is. I work in a hospital on mother baby, so something we give out is this form, which tells you things that you should look out for, who to call, whether it should be 911 or whether it should be your healthcare provider. So some of those things include chest pains, seizures, if your incisions are not healing, if your temperature is high, that indicates infection, and if you have, like Tanisha said, a headache that does not go away with medication or causes changes to your vision. So how does New York state law protect you as a patient? You're allowed to know your rights in the hospital setting. So that means what treatment you're receiving, who you're receiving it from. I know a lot of nurses also advocate that you know who each provider is and who you are speaking with, what their role is when they come in. You should know the people that are providing you care. You're allowed to have copies of your healthcare records, and hospitals have to help you understand your care by any means. That is why care plans are established. That's why they're also followed through. So how is New York City specifically addressing this disparity? So the first project they've worked on is the Severe Maternal Morbidity Project. This was a project implemented with 3 strategies. The first one was to improve the quality of maternity care at a hospital, learning about mothers' needs, their specific needs and their experiences through severe maternal morbidity and the ramifications of severe maternal morbidity on their lives, and to inform action and further research, as well as informing and supporting mobilization of communities around maternal health. Another resource that was put throughout the state just recently, I think not too long ago, Ms. Tanya Moore-Murray over there was also a part of some of these. We have the Maternal Hospital Quality Improvement Network. This is comprised of 14 hospitals throughout the city. They all follow the same improvement standards so that there is a set guideline on how patients should be cared for in order to reduce some of these morbidities and mortalities throughout the state.
Sorry, everybody, time out. They just can't hear us on Zoom. I just want to fix that.
Okay, you can fix it. You're fine.
Sorry. Hold on. Can y'all hear us on Zoom? They looking at us like we're crazy. Can y'all hear? No. Still can't hear. It's all right. It's not gonna work out for them now. Yeah, I'll fix it for them. Got it. Well, you can share screen to them. And then you go back into our whole, yeah.
And the last resource in New York State is also known as MERC, the Maternal Mortality and Morbidity Review Committee. This committee looks to reduce preventable maternal deaths and eliminate any inequities within the state. So what they do is they want to know each mother's journey specifically to determine their causes, assess what preventabilities they have, and identify factors and recommendations to prevent future maternal deaths. So in conclusion, this is a concern for all of us. This affects people we know. This affects our own families, and for some of us Black women, it affects us personally. It is our right to have access to this information, to know where we can get help, and to make sure that we have the 4 R's is I guess what we call it: readiness, recognition, response, and reporting. So that is all for our presentation. We can go back to the front. I'm going to go back to the first page. You want to introduce our panelists?
So at this time, we're going to ask for the providers on the panel to please join us at the front. Yeah, so that's what we're gonna fix now. That's what we're doing before we get them started. Sorry.
Oh, okay.
I don't know why they can't.
You can hear some sound now.
They said they can't. Yeah, I don't know why they can't.
Did anyone grab a card from the entrance, a note card and a pen?
Kayla.
If you did, we ask that you just fill out any questions that you may have. If not, I'm gonna go around and just give a note card and a pen then, okay?
It's a sound is good.
Does anyone on this side need a note card and
No,
a
we'll
pen?
change the view. But the sound is good now. All right, the view is. This ain't what I do. Rolling chair.
So good afternoon, everyone. I'm Tanya Moore-Murray, and I would like to introduce our panel. I would just like to say thank you, ladies, first of all, for coming and joining us today to talk about this very important issue. In addition, I'd like to add, we also had a midwife and a doula due to present today, but because they are dealing with birth, unfortunately, they won't be here. So I will join the panel also at the end, just to give you my spin on things. So first, we have Dr. Oluwakemi Adegoke. She is an attending physician at Jacobi Medical Center in the Bronx. We also have Ms. Dawn Africa, who has a number of years as a nurse in the labor delivery postpartum areas, and she has a wealth of knowledge just about nursing itself. And lastly, we have Ms. Rochelle Werner. Rochelle is the Associate Director of Social Work for the Maternal OB program. I'm also going to join the panel. I'm Tanya. I'm a nurse, women's health nurse, or, yes, for over 20-plus years of experience. I was an L&D nurse. I also worked with quality improvement. I was a perinatal obstetric safety officer. I've done some research, and now I'm Assistant Director of Nursing of Ambulatory Women's Health and Pediatrics, currently at a hospital in the Bronx. A lot of years and a lot of experience in this area. So with that, here's our panel.
Test. Can y'all hear us now on the panel? I'm sorry, on Zoom? I did. Share sound. But if not, we're gonna mute and we're gonna put a phone there so that they can hear. No, they can't hear. All right, cool. That's fine.
Or we can try and go into the mute option, and then we can click to mute on Zoom. Can you see me here?
All right, check. Mic check. Yeah, they can't hear. So what we're gonna do is place a phone.
Maybe microphone? Try now.
Check. Yes.
Can't hear? Okay. They can hear.
Yes. Look at that. Yeah.
Yes. So you can ask the first question.
You got their background? Yes. Introduce themselves? Yes. Your background?
Mhm.
And go ahead.
Hello to our lovely panelists. How are you today?
Hi, sorry. So with so much extensive background, can you just each one by one talk a little bit about your personal experience and your specialty with maternal health and morbidity?
And how it's affected your lives.
So let's start with Dr. Adegoke.
Hi, my name is Kamende Goke. I think I'm probably maybe the youngest person on the panel. I'm an OBGYN. I have experience with maternal care in the U.S. and across the world. I did a global health fellowship, so I have seen maternal care in the U.S. and maternal care particularly in Kenya and Tanzania. So I've seen women pass away and die across the world. So it definitely is something that has affected me throughout my career. So I'm a big advocate in women advocating for themselves and women speaking up when they don't feel well. So I think that this is something that is very important to me. So when women are labeled as, especially Black women, when they're labeled as non-compliant or being difficult, especially in the labor setting, which I do still hear all the time, I get very frustrated. So I think that when I'm hearing the presentation about knowing your rights, that's very important. I think that's the biggest thing, is that advocacy, especially the patient advocating for themselves. That's a very big issue, and I think that the patient is their number one advocate. So a lot of these things, when we look back at, when we're looking at the situations where women have died in pregnancy, and we're looking back at those situations, we realize the vital signs changed a long time before that patient died. And we realized that something could have been done a long time before the patient died. And we realized that the patient probably said something a long time before the patient died. So listening to the patient is very important. So that's just kind of why this subject is very important to me.
Hello everybody, I'm Dawn Africa. My accent, as you can see, is a Caribbean accent. I'm proud Caribbean. I have just ended my 37th year of nursing. Yes. I started off, I did a British-based nursing program for which you go to every department in nursing. So I started off in medicine. I thought I was in heaven. And then when I left medicine, I went to surgery. I thought I was in heaven. I thought it was the best thing. Then I went to the emergency department. Again, I thought I was in heaven. When I went into midwifery, I became a midwife. I knew that was where I needed to be. And I've never left OB since. So I practiced in the Caribbean as a midwife. I will tell you that one of the things that impacted me as a midwife in the Caribbean, now in my small island, everybody is related to everybody. So you try to give the best care that you can, because somebody on the bed is going to tell you, I know your father and he's my cousin's cousin or something. There was this particular lady, and I have never forgotten her. She had spent some time with us in OB because she was a placenta previa patient. So she spent some time, and at about 35 weeks, they let her go home. She came back at about 37 weeks, and we were happy. We felt like we were family. We were happy to see her. So she was in labor. We took her in, another midwife and myself. And when she got into the second stage and she was pushing the baby, she just stopped suddenly. But before that, her husband had come to the hospital. And the practice was to ask him to wait outside. So he was out there waiting outside while she was in there dying because she got a pulmonary embolism. And she did die, although we were able to save the baby. And that really impacted me as a nurse, that fathers were left out of the equation very much. You know, I don't know how many of you know the Caribbean islands, but that's just how it was at that time. Mm-hmm. Since then, my practice has been that if there is somebody she wants in the room, and she really wants in the room, that person has to be in the room. So that's where I'm coming from, and that's what I believe in. And when I see some of the practices now where it's either the mother or the partner, those things really bother me in the area of maternal health. I'll hand over to you.
Good afternoon, everyone. My name is Rochelle Mercer. My current title is Associate Director of Social Work with the Maternal Home Program, previously known as the Maternal Medical Home Program. I've had several years in the outpatient women's health clinic providing service to women, pregnant women. More recently, as I said now, for the past 2 years with the Maternal Home Program. I get the pleasure of working with, of course, the population and women who have all sorts of issues. This program, the goal is pretty much to help to minimize social determinant of health factors, to help them have as healthy as pregnancy as possible. More personal for me, I'm now 7 months postpartum, and I'm sitting here by the grace of God as I had experienced postpartum hemorrhage. Very scary and traumatic situation where after birth, my newborn was separated from me. My other half and my mom, who were also in the room, I'm now rushed out of the room after what was supposed to be a joyous occasion. So I do my job prior to becoming pregnant. I do my job wholeheartedly. And now having that experience, the passion and the drive is even more real. So that's why I sit here today.
So with that being said, I'm here today for a lot of reasons. Number one, professionally, I have experienced maternal death more times than I would like to say, right? And at we had four deaths within 2 years. So I clearly have post-traumatic stress with regards to this. And that, right after that happened, my own daughter was pregnant with her first child. And so for moms in the room, I will just say this. When your son has a baby, because my sons have had children prior to this, it's just different than when your daughter does, because she has her mom, they have their own cultural things or family things that they do. But when your own daughter is pregnant, it's just different, right? It's like, this extension of you. And so dealing with this post-traumatic stress, it was very difficult for me to be excited, number one. And number two, I was so scared because of all the things that were going on. So now at this time is when all this information, 2017, she was actually born in 2014. So around that time, you hear about all of this maternal mortality and morbidity, and we were like, what do you mean Black women are dying having babies? So now I'm so fearful because of what I had just experienced the 2 years before. And so one day my worst fear came to fruition. My daughter called me screaming to the top of her lungs. Her co-worker, who she worked with, they were all both pregnant together, the co-worker and the baby died. She didn't know why. But of course, that was traumatic for her. It was traumatic for me. And then in addition to that, my youngest daughter, who at the time was at Spelman College in Georgia, her professor, sister passed away. And he became the guardian of his niece. And so his sister was a woman who was well educated, et cetera. So again, socioeconomic status has nothing to do with this. Mm-hmm. So this intrigued me and, wanted me like, this is so important to me. And so this is when people started really talking about this, and the Safe Motherhood Initiative came to fruition. And this was an initiative by Merck, the drug company. And there was a lot of money put into this for obstetric patient safety. So I became an obstetric patient safety officer, right? Because this is what I wanted to do. And my boss at the time, there was a box and had all these brown faces on it. And my boss at the time, because I was leaving to go to another location, we wanted to know, well, why was I leaving, et cetera. I said, you see this box right here? Everybody on that box looks like me. And so I think it's important for me to be a part of this. Went there, and during that time, myself, Dawn, and Dr. Floyd both experienced the death of a mother and a baby, but we were right there. It was hands-on, and it just happened so quickly. And yes, sepsis was the problem. But when I tell you, when they talk about the second victim, we're providers as the second victim are so affected by this because we were. There was not a dry eye in that room for every person that was involved in that situation. I'm talking about the surge, because she ended up in the OR. I'm talking about every doctor, every tech, every nurse, anesthesia, the people who were cleaning the room, everyone. But my role at the time was very different, because now as this patient safety officer, myself, Dr. Floyd, who was a nurse manager at the time, and the attendant physician had to go and talk to this family. Mm-hmm. You cannot imagine what that was like. It's horrific. Mm-hmm. And so with that, again, being such an advocate for this, why is this happening? And so I stayed in that role for a little while, and I left to the current role that I'm in. And in this role, I feel that I'm trying to be a part of the solution and not the problem, because that's what we have to do, and that's why I'm a part of this committee. It is, our job, the providers that look like us, in addition to other folks, but it's personal to us, right? And so it's our job to have our patients advocate for themselves. So I actually am the manager over 2 clinics, mommies and babies. And we put together a program where we're trying to combat this, where the moms and the babies are coming together after the babies are born, right? So this is a way, hopefully, that we're trying to combat maternal mortality and morbidity, because we found that in our hospital, like most others, moms are not coming back for their postpartum appointments. They're just not coming back. And if it's a choice between the baby being seen on the first floor and mommy being seen on the 3rd floor, what if you have a C-section and you got to bring the cat? It's too much. So we have a co-location where moms and babies are coming together for the baby's first visit, mommy's wound check, mommy's blood pressure check, as well as the baby's first visit, and then postpartum and the 2-month visit, right? And so just within the past few weeks, because I'm a very hands-on manager, I myself took moms back up to labor and delivery because the blood pressures were through the roof. What if they would have stayed home? They could have seized and their babies could have been motherless right now. So these things are important. And it's not, moms at one time used to stay in the hospital for a whole week, but they're not any longer. So they'll go home in 3 days, and that's when the blood pressure is going to peak. So this is why it's important, but not only that, during that care, we're supposed to give out things like this. Are you pregnant? This is New York City. Are you pregnant? We can provide you with a doula, somebody to help you and assist. This is free. You're not paying for this. In addition, this is something that we recently got, I don't know, I just ordered it. It says, hear her concerns. This is what everybody on this panel is talking about today, right? Learn about urgent warning signs and how to talk to your healthcare provider. If you're pregnant or you gave birth within the last year, it's important for you to talk to them if something doesn't feel right. And it tells you all the signs and symptoms. But this is what New York City is doing. You see, Louisiana was on the top of that list. I don't think they're doing this.
No, as someone who practices in the South,
They're not doing this, right? And so this is why this is important, because we need to say to our cousin in Georgia, listen, if you experience this, and the other, this is what you need to do. And the other thing is that, the internet is just so available to everybody. Read about what is going on with yourself. I tell these moms, you got a smartphone? Put your blood pressure in your phone. Every time you come here, see what the blood pressure is. Because if you have a range, then that means something is wrong. And speak. And the thing I try to impart on our nursing staff is, guess what? Advocate for your patients. Advocate for your patients. If there's a problem, address it with the provider. And guess what? If they're giving you a problem, that's what I'm here for. Escalate it.
True.
We have to, because if we don't, patients not being heard is what she said, one of the biggest problems. And like she said, blood pressure, how long are we not watching it?
Yeah.
The other thing that we're doing, and I can say that I'm proud that we're doing this, is simulation. I've been involved in simulations myself. I've run simulations. We're actually going to do one today. Miss Campbell's here, and she's going to help us with that. But that's one thing that we're doing that is so phenomenal, that wasn't happening 8, 9, 10 years ago. And I can say that because of the training that the staff in my hospital on labor and delivery had, last year there was a mom who went into cardiac arrest after having an epidural, and her baby, she coded. I could hear it. I was in the clinic and I heard the code. But she walked out of there with her baby. We had the same situation in another hospital, same year, and guess what? Mommy and baby died. So unfortunately, even though we have standardized these things in our city, but again, it's the team. The team has to buy into this. And if they don't, that's when we start to have issues. I think we've We've done good work, but we have so much more to do, and it is everybody's job. So everyone is in this room, take one of these. If you know somebody's pregnant, I mean, you don't have to take it, just take a picture. And send it to them, because this is so important. And guess what? If the person that you're listening to doesn't want to hear you, then guess what? I want to speak to your supervisor or your supervisor or your supervisor. Because guess what? There's a study of residents not too long ago. Guess what? They still think that black and brown people can tolerate pain much more than others. That's a little ludicrous to me. But it means that people really believe this. And we all know that that's not true. It's not true. But this is what folks believe. So again, it's our job. I hope I was able to impart something on everyone. Thank you.
So as professionals, a question that has come to mind, we ask a lot for patients to advocate for themselves. When they're in a setting with people who have credentials higher than them, who feel that their voice is not heard, how do you believe that they should advocate for themselves to those professionals, whether that be the provider, whether that be the nurses, whether that be the lactation consultant? It can be very intimidating in a healthcare setting when people feel that they know your body best. So as professionals, how do you maybe make the room more comfortable or be more open to allow patients to do that?
I think that we need to ask open-ended questions. And it's very obvious when a patient doesn't understand what we're talking about. Like, the patient has a confused look on their face. They're just answering yes and no. Like, don't just say, like, do you understand? That's a yes and no question. Like, you need to be like, what questions can how can I help you? Like, how can I make your care better? What things don't you understand? You know, ask open-ended questions. I think that's a way, like, and tell them, like, there's no silly questions. Nothing is too, like, silly. This is your body. I want to make sure that this experience is the best for you, best possible. So just make sure that they feel comfortable. I think that's one way to make sure that a patient feels comfortable in asking and advocating for themselves. So that's maybe one way to go about doing that. Because I feel like patients feel uncomfortable when you make the assumption that they understand everything you're saying.
So I do agree with you. I believe in the power of teach back. I think that too many of us as healthcare providers think that advocacy is combative. Okay, I'll tell you of some experiences that I have had. As recently as this week, I went to a clinic and somebody had to do the preliminary stuff so that I could, get the test that I went for. And they said, come in, and they were very nice. And then I sat down, and he takes out a tourniquet to take. I'm like, who are you? Simple things like that are things that we need to look at. If I could take the word if I could take the phrase, do you understand, out of healthcare, I would. Because when we ask the patient, do you understand, the patient thinks that we're speaking down to them. You nurse, I patient, of course I understand. They're not there in the affirmative because they don't want us to know that they haven't understood. Rather than asking questions like, if you were to go home and your daughter asked you to explain what I told you, what would you say? Or just to be clear, because sometimes I don't explain properly, because once you put the onus on the patient, you are embarrassing them, you are preventing them from opening up to you. So it's a matter of finding a place, a safe space for that patient to be able to advocate for themselves and encouraging them to do so. Okay? In some hospitals, and maybe you know the hospitals, there are patients who come in and they say, oh, she is such and such an ethnicity, or such an, she can tolerate that. When she says the first, the baby is coming. People say things like that.
True.
patients walk in, and at one of the facilities where I worked, I had real issues with some of my nurses. Because if somebody came in looking lily white with brown hair, with blonde hair, they would, oh, she's German, she is whatever. We need to use the interpreter phone. Somebody came in who was Hispanic or French, African speaking French, they would be miming. Mami, dollar. What's that?
Yeah.
You know, agua. You know, come on.
Making a lot of assumptions.
We have to do better than that as healthcare providers, because what I'm finding is that we, the people who look like me, who are saying that there are disparities in care, we are perpetuating those behaviors, maybe because we are integrated into the structural and, you know, into the racism, okay, because our organizations tolerate it. But we are perpetuating those behaviors.
Yeah.
Okay? We join the others who would say, oh, she's a princess in there. She keeps calling me. You know, we have to look at ourselves, because if we don't, I mean, we are just what? 8% black nurses, 9%, somewhere around there, 80% Caucasian. They're not going to change this for us. We have to change it for ourselves. We have to start making the change. And we have to start advocating for our patients and allowing them to advocate for themselves. The other thing I'm finding, and I'm passionate about that, where's Dr. Floyd? Is that we do not routinely assess health literacy for our patients. We assume that we are speaking to them and they must understand, because we are nurses, so we are speaking to you, you need to understand. Okay? So I tell you, take your medications twice a day. I don't even tell you what it can do, what's the side effects or anything like that. And my expectation is that you take your medications twice a day. Well, why should you take it if you don't understand what you're taking and why you should take it? You know? So there's not that verification, there's not that dialogue that goes on between provider and patient, where we make the patient feel safe enough to say, what's that? Okay, I will not take one, I'll take two, because I went to the doctor and the PCA did not take my pulse. She took my blood pressure, she documented. I never said I was a nurse. And when I went into the doctor, he says, you know something? We have to do this cardiac test for you, but we need to slow your heart down. So I'm going to give you low pressure, 100 milligrams. And I said, why 100 milligrams? He said, because your heart rate has to be slow enough to, you know, to take the pictures. So I said, what's my heart rate? He said, it's 87, we really need to slow it. I said, I'm sorry, sir. My heart rate normally runs, my resting heart rate is 60 to 66. He said, okay, so I'll give you 50. And if when you come in, it's not, you know. But no, she did not even take my pulse. But if I couldn't advocate for myself, I'd have gone home and take the 100 milligrams. Guess what? I took the 50 he gave me, and my pulse went down to 40 and stayed between 40 and 53 for the whole day. So those are the things that happen to us who can advocate for ourselves. Imagine that immigrant who comes into our country, is afraid that, never understood that when you come in for healthcare, they won't report you as being illegal or whatever, is afraid to come in. They take everything you give them. You know? I've had providers walk into the room and say, I'm going to examine you. And just move in on the patient in the most private area. I'm like, no. When you see Nurse Africa's name by your patient, do not touch my patient without talking to me. You know? Walk in and rupture membranes. You know, private physicians, because they have to go to that office. You know, and I'm like, don't touch my patient unless I'm in the room. So when you come into the OV, I say, let me clean her first, because I think she has a right to be clean before you put your fingers in there. You know? So things like that, we have to stand up for our patients, and we have to help them to stand up for themselves.
So on the social side of things, advocacy is what we do. First off, when and I say my patients, so excuse me, because they're mine. When they're referred to me and they come in, the first thing I do is listen. And whomever I'm working with, I encourage them to listen to whatever the patient is saying. There are ample times that the patients will come into my office and the referring reason is just not the same from what the patient's concerns are. And I can only imagine the type of conversations that's occurring on the side of the door with them and the obstetrician or the midwives or whoever they're meeting with. So that's critical. Cultural competence and implicit biases are critical in the healthcare setting. In my own personal experience, I'll tell you what, my doctor said, y'all Caribbean women, y'all strong. Mm-hmm. And I'm in the bed trying to open up my eyes from all the anesthesia, and I'm like, what? Like, my senses are here, but I'm not able to respond. So in regards to advocacy, what I try to tell my patients is, listen, if there's something you're not understanding, if it's not clicking, if you have to raise that eyebrow, ask a question. If you're at home, write it down. We have all these technical devices around. Use your resources. Go in your notes app, create a section for your prenatal appointments. Put those questions in there. And when you come for your appointment, you're not able to miss out on those questions because you're not overwhelmed with what's being told to you. In regards to patients who have diabetes, the phone as well. A lot of them aren't, checking their levels and doing what they're recommended as per the doctors, but it's all because of knowledge and education. So using the phones to set alarms, using me to ask a question. Some of them don't have the insurance to get the equipment that they need. Just call. But for the most part, they're not really, in tune and aligned to just reaching out because of what they've experienced. So they just don't want to. So I just try to push it on my end, that's all.
And I'd like to say ditto to all they said.
Okay, so we want to have a little open Q&A if anyone has any questions that they'd like to ask these healthcare professionals. Feel free to.
I have a quick question. Let's say you are an individual that does not have the kinds of language to advocate for yourself, or you do not have a provider that listens to what you have to say, that constantly disqualifies what you have to say. What are the steps that you need to take as an individual to develop that kind of language and to advocate for yourself when you will have a provider that constantly discounts what you have to say?
I mean, from my end, I've had that situation where the patient just doesn't feel as though the doctor was listening, whether it be a language barrier or whether it just be a disconnect. And I personally have either, and Tanya is my ADN at my hospital, either taken it to her, my head physician assistant, whoever it is I need to take it to, that's where it's being taken, because if they're not connecting there, then we don't have healthy outcomes.
So I also would like to add to that. As far as language is concerned, we do have a language line that we call, it's a dual phone, what we call, and it's multiple languages. These things is reading my hands, I'm sorry. Again, multiple languages. In addition to that, if there's an issue with a provider, whether it be a nurse, doctor, whatever, I actually had a situation where one of my PCAs came to me, And she said that a patient was crying, so evidently to say the patient was having a sonogram performed, and then in addition to that, she was having a prenatal appointment. So she goes to the prenatal appointment, this young lady is crying. She was Spanish speaking, so she spoke to her and told her that the sonographer was rude to her, right? And so I said, okay. I came in and I went and I spoke to her myself. She translated, et cetera, and explained everything that happened. And so this person basically said she was able to articulate a little bit of English, and when she made reference to something else and the person didn't understand, she said, oh, you know how to speak English, or something to that effect, right? So I had to take a deep breath when I heard that. But what I asked the patient to do was to send me an email, because I needed to address that in real time, right? Which we did, and it was taken further, because that is not acceptable. There have been situations where it has come to my knowledge that a particular provider, the patient doesn't want to see this particular provider, whatever, and then we make arrangements that doesn't happen. Or I'll bring it to the vice chair or the chair or the medical director of the clinic, and I can honestly say we have a good working relationship, and we deal with things, because I personally feel that the team that we're on is a team. There's no hierarchy. Who cares about the letters behind your name? This is a team, and we have to work as a team in order to provide for our patients, and I believe that is the belief of most folks that work with us. And of course, it's always somebody that doesn't agree or doesn't work the same way. But again, it is my job to advocate for these patients, but also to empower my staff to be able to advocate for the patients. And that's what we do. If there's a problem, you gotta let me know, because if I don't know about it, how can I address it? How can I deal with it? That's how we deal with things. But again, I would suggest any patient who doesn't feel comfortable with regards to how their care is being administered, et cetera, there's always patient relations in the hospital. Mm-hmm. Go to patient relations. There's some people that live there. And make your complaint, because when somebody gets a complaint from patient relations, I hate it because I have to then investigate the situation, respond back within a certain amount of days. So that's how it works in the hospital where I work. If a patient goes to patient relations, we have to deal with it and respond and decide, or say whether it was substantiated or unsubstantiated. But there is an investigation. Patient relations, or if it's a small clinic, whoever's running the place, because we have to empower folks to advocate for themselves.
Well, one of the things I took the liberty of looking up just for the purposes of this and to get clarity. New York State does have a patient bill of rights for hospitals, and it's very clear. And if we were to follow it, no patient would be discriminated against or disenfranchised. And one of the things is that they have a right to participate in all decisions about their care and treatment, including up to and including discharge. Okay, they have a right to refuse. They have a right to being spoken to in a language that they can understand, and it's outlined. I have a few of the rights here, but there are 21 in total. And up to and including billing, it tells them that they have a right to an itemized bill. So the problem we have, though, is that although this is here and it's available, nobody tells you when you come into the hospital, these are your rights in a language that you can understand. It may be posted somewhere. They'll say it's posted outside the door. Who has time to read the door when you come in pain and you're ready to deliver? So maybe we just need to do more about moving around and letting these patients know that you have rights 1 to 21 if you are in New York State, so that they understand these rights. And because they understand the rights, and the healthcare providers know that they understand the rights, they take a little more care in attending to these patients because the rights are very clear. You could look them up. Each one is well outlined. And I looked at them and I'm like, wow, if we were just to follow these rights, no patient would have to complain. And they would definitely get the attention that they should.
We have time for one more question.
I have a question or comment, actually. Number one, thank you so much for bringing this to light, to awareness. I'm a board-certified family nurse practitioner. I work in women's health or OBGYN, and I definitely try to be the change I want to see. I didn't know this was a problem until I would walk into rooms where I had patients of color, and they would say, "Ooh, thank God, it's a woman of color." And I would be like, "What do you mean by that?" They were like, "Well, the last provider that I saw, and in our practice is only 2 providers of color, myself and another sister." They were like, the treatment was horrible. They felt invisible. They were belittled. Their questions were dismissed. And I also agree, advocacy is number one. I'm like, you're always in a position to leave a practice, get your medical records, and get a second opinion. You do not feel seen. You don't feel safe. This is you and your baby. Leave. And I do see that non-Black counterparts are more likely to come into the practice. They'll leave another practice and say, you know what, I didn't like my treatment there. I'm shopping around for a new provider. So I think that's something that we need to encourage women of color. As mentioned, knowing the statistics, 1 out of 3 are 3 times more likely to die from a pregnancy-related death. That's outstanding, and it's not okay, and it's continuing. Whether it's postpartum hemorrhage, ignoring vital signs, and you know that this stems back to slavery as well, where you know gynecologists were doing surgeries with no anesthesia on women of color, and then that notion continued that women have a high pain tolerance, and that's incorrect. So I think training, number one, with the healthcare providers. We know that structural racism exists, but we really have to do things like this, awareness, just protesting, whatever needs to be done, education on diversity and inclusion, and definitely encouraging patients to advocate for themselves, because it's a real thing, and females are scared, literally scared, where now I have patients of color that only want to see me because they're like, I feel comfortable, I feel like you understand me, and it shouldn't be that way. Everyone should have an understanding when it comes to health and safety, so thank you.
So let's give a hand to our providers. So much for your time. It was a pleasure being able to hear from each of you and your expertise.
Thank you.
Thank you.
At this time, we're going to have a 10-minute intermission before going into our simulation.
And thank you so much for having me here today. You're about to take part in an education and training that happens across New York City for New York City Health and Hospitals. This particular simulation is, I'm sorry, just put my mask down. This particular simulation is one that was addressed in the slides, and it's regarding obstetrical hemorrhage. Obstetrical hemorrhage is one of the highest mortality for moms in our system, and especially for our Black and brown communities. In this simulation, we tried as much as possible to make it look real, to provide some fidelity for you. For the providers in the room, it might meet that need. For the people who are not clinical providers in the room, it might be a little scary. So I do want to preface this simulation with saying that we tried as much with the blood that's there to make this look real. And this also might trigger people in the room, right? I've heard a lot of people this morning share some stories about being a patient and a provider of birthing patients, and this might be something that might drum up some of those feelings for you. If it does, please find an exit to the room, and we will make sure that one person from our team will be checking back with you to make sure that you're okay during the simulation. It's actually really short. I hate to be the person between lunch. I hope that you enjoy this simulation. The simulation itself lasts about 5 to 6 minutes. We will do the simulation. We will allow everyone to grab something to eat, and then we will transform into what we will have as our makeshift debriefing space, where we have discussions about how to care for a birthing patient who has postpartum hemorrhage, and how we actually dip our toe into some of those implicit bias questions and things that might come up for our healthcare teams as we're caring for this community. Is that okay with everyone? Awesome. So, everyone, just a minute, so stay. Yeah, so I'm sorry, I'm sorry guys, one more thing, just come in 1 second and introduce yourselves and tell everyone what your role will be in the simulation.
Hi, everybody. My name is Sunal. I'm going to be the primary nurse.
I'm Canadian, okay, I'm the physician.
I'm Dielle, the secondary nurse.
I'm Daphne, I'm gonna be the checklist reader. And I'm Kimberly Campbell, I'm gonna be your patient.
And I am Clement Clark. I am the father of this beautiful baby right here. No, it doesn't. Oh, good. More for
Where's the IV? Can stay out?
you want to say that?
Hi honey, how's the baby doing?
Baby's fine. How are you doing?
Oh, you know, I don't know, I just feel so lightheaded and dizzy. I just don't feel like myself. But maybe this is how I'm supposed to feel after we have the baby.
Okay, well, hopefully somebody's coming in. I think our nurse is.
Hello, Miss Clark. How are you?
Hi, I don't feel like myself. I feel really lightheaded and dizzy, and then a little while ago I just felt like this gush come out, and I'm not sure what happened.
How long have you been feeling like this?
Oh, maybe like for the last 20 minutes.
Okay, I'm going to press on your belly like I've been doing before, okay?
Okay.
Take a deep breath for me. Okay. All right.
I'm
You
so
have a lot of
scared.
bleeding, so what I'm going to do is I'm just going to have some more people come into the room,
Okay,
okay?
that's a lot of
I want you
blood.
to take some nice deep breaths, and then you can take a seat with the baby, okay? I'll be
Okay.
right back.
I'm just so scared.
I'll use the call bell and call people. Come on in. Instead of leaving. Okay. So what we're gonna do is we're gonna take your vital signs. We're gonna take care of you.
Okay.
Hello.
Hi.
Hi, Dr. Daly. What's going on?
There's a lot of people in the room.
My third check and see that she has a lot of bleeding.
What was the original EBL?
450.
We're vital right now.
What's that sound?
90
over
over
50.
50.
Okay. What, do we have a leader?
Yes. Giving you fluid now.
Like I'm gonna catch out.
Give them another gen.
Can we fix the sound? What's going on?
Do we have IV access?
Does she have history of hypertension?
Yes, I do have an IV.
So we're giving the Methergen. Methergen given.
Did you have asthma?
No, I don't have any asthma.
Okay, all right.
Giving the Hemabate.
Did she get meso?
Have we increased the IV fluid?
Can you give the IV
Did
fluid?
she get meso when she first delivered?
No, she didn't get any.
So let's give her meso.
Okay, given the meso.
Give her Methergen.
I feel like I can't
And then
breathe.
our bleeding is
Can't
now.
breathe. Somebody help her?
Let's talk about
Oxygen, where's the oxygen?
So
Where's the oxygen?
right now you're bleeding a lot. What I'm gonna do is just to check you to see if there's any where you're bleeding from.
Okay.
I'm gonna do an exam. It's gonna be pretty painful, but I just wanna see if there's any bleeding from like tears or anything like that. Okay.
Okay.
Check. What are repeat vitals? Okay. Repeat vitals.
Ow!
It's okay, she's losing.
And what about a catheter? Are we gonna insert a
Okay.
catheter?
Can we take a Foley? Do we have Foley?
Yeah, inserting a Foley.
Okay. All right.
We're at 1,000 of bleeding.
What's the
now.
repeat vitals right now?
Double checking, have we completed the fundal massage?
Okay.
I put on the oxygen mask.
Okay. So we may take her to the OR.
Okay, we're going to the OR.
Okay, so right now, sir, she's bleeding a lot. We need to stabilize her bleeding, so we're gonna take her to the operating room just to see better, have a better view of what's going on, okay, and stabilize her bleeding.
She gonna
okay?
be all right?
We're gonna do what we can for her to make sure she, is okay, okay?
Okay.
So we need to have 2 large bore IVs. We're gonna take her to the operating room. We need to get blood also. We're gonna call basket transfusion also, okay?
All right.
Simulation complete. So we're just going to take the opportunity to have a timeout. One, we're going to grab some food, and I need the people that were in these roles to decompress for a minute. And we're going to meet back here as soon as you grab something to eat for debrief. Everyone coming down to the right. Awesome. Put this here.
We should have looked at our supplies. No, I did. I knew where they were, but I didn't realize it.
I was like, I don't have anything. Thank you for, I was like, I forgot the method. I was like, oh yes, hypertension.
Come on, give me these. Kim, where's she at? Kim, can we throw these out? Wait, does she have asthma?
There were a number of facilities where embolism was the cause. They didn't catch it, so they ended up resuscitating this mom. So that was the first topic at each of the 11 facilities. The second one was postpartum hemorrhage, which you just experienced today. The third, which we are currently doing, is shoulder dystocia. Hypertensive crisis is next, and sepsis. So we schedule simulations 1 to 2 a week at each facility. Because what I do is hospital-based, OB units are like mini emergency rooms. You can schedule as many as you can or you might want to, but they might not get done just based on the acuity and the census. So knowing that about 25% of them don't happen due to no-go criteria, which means it could be the census, it could be acuity, it could be a C-section, it could be something going on in that unit in which this doesn't take precedence. But 1 to 2 times a week, each facility is scheduled for a simulation. So American Heart Association says that 3 months, 90 days. If you don't use it, you lose it. So going into the facilities, making sure that they get re-inoculated with this training is super important for the knowledge to stick. Great question. Any other questions?
So I just want to add that these hospitals are part of, New York City system, but these are the hospitals that are treating more than 50% of the Black and brown women that are affected by this. So this is why this program is very important.
Any other questions?
How often are these type of simulations integrated into nursing schools, integrated into PA schools, integrated into medical schools?
That's a great question. So when Dr. Johnson took me over to the nursing simulation building, I was like, this space is so cool. I was like, you guys hiring? I love this place. It's like awesome. Because they have simulated spaces inside facilities, which I haven't seen at other universities. And look how important the timing of that is. So we're looking at the last 2 years, we've had all of those professions graduate without touching a patient. Right? Imagine that. They did not touch a patient because they were not allowed to go into these healthcare facilities to actually get hands-on clinical care. So simulation is super important because the nursing education world is saying, so how do we supplement that? Since we don't have, what do we do with this? And they've used simulation, different types of VR, gamification, to try to meet those needs. So I would have to say, every school does something different because of how they meet their needs and their standards. Unfortunately, I don't have an answer for how often it's done in universities. I think it is a great opportunity. I don't think it supplements really taking care of patients, right? But I think it's a methodology. It's a teaching methodology. It's that dress rehearsal before it really happens. That's what simulation is. And the debriefing provides an opportunity to have some open discussions about the what ifs that might happen. So I wish there was a standard to that. I know NLM is looking into what they want to be a base for how long, how many hours they want that to be. I don't think they came up with an answer, and I think it's because COVID kind of hopped in and took over that space. But great question.
I do have a comment towards that because I work in simulations as well. One thing that I've noticed working in different institutions or institutions of higher education with regards to simulation is sometimes there's a gap in between when people who are in education have been practicing. And sometimes what happens is some of the most recent, I guess, changes that have been made or most recent best practices, sometimes people in education are not aware of that. And so it causes us to have that lack of education to be able to educate in the simulation department. So one of the things that I feel like is necessary is for people who are still at the bedside and in the front lines to communicate with facilities or institutions of higher education so that we can bring together that gap in knowledge as well. Because just working in different simulation centers, I've noticed that.
Absolutely. So I do agree with you. The problem is that when we become healthcare professionals, for those who are healthcare professionals in the room, it doesn't stop, right? It reminds me of cultural competence. Cultural humility is a nicer word because competence means I'm competent and I don't need to know anymore, right? Same thing with education. You need to keep going. It is the people who are recently graduating that have that knowledge. I think, again, nurse educators in particularly, they feel vulnerable when they say they don't know, right? And it's that vulnerability of not knowing, but I'm the educator and I should be the one that knows, that kind of gets us into trouble, right? We're all in the process of learning, and there's something you can learn from everyone, but also making sure that you're up to par on what the evidence is, and using subject matter experts. There's no way I could get up here and teach test tube, right? I could teach you how to support the person who might be inserting it, or some of the things that might need to happen. But you need to find in simulation, which is extremely important, is the subject matter experts for these things, and you have to collaborate with a team of people who know what's happening cutting edge. And you have to continue your education. So absolutely. Because you could be teaching old medicine or old healthcare, and whoever you're teaching takes that negative learning to the bedside. Is our team ready? I'm sorry. Our team who was inside the simulation, we're just going to do a quick debriefing. I promise I'll make it fast and painless. So customarily, when this is done in the hospital base, after the simulation, we do what is called a debriefing. The debriefing is an opportunity for learning and talking about what went well, what we might want to change for next time, some of those takeaways that might happen for our team. We love for it to happen right after the simulation. We wouldn't want this gap to happen because we also want to hear some of the emotions of being in that sim, and we didn't want to lose that. Okay? And I would not be standing over them. I would be sitting at your eye level doing this. I just want to take this opportunity to write on this board a minute. So good afternoon, ladies and gentlemen. My name is Kimberly Campbell-Taylor. We're going to actually have a discussion about the simulation that you were just a part of. Could you do me a favor and just go around the room and say what your name and what your role was in the simulation?
I'm Kimberly, okay, I was the physician.
We have a physician. Go ahead.
I'm Daphne, I was the checklist reader.
I'm Dayelle, I was a secondary nurse.
Samel, I was the primary nurse.
Clement, I was the father.
Awesome. So really quickly, if I have your permission, I'm just writing on the board, and what I'm actually writing on the board is a list of things that was done well in the sim, and things if we had to push the needle 1% to be better, what those things might be. I just want to take the opportunity to say that it is usually a system or a process. When we make a misstep in healthcare, not always an individual because it takes a team. I also want to say that what happens in this debriefing stays in this debriefing. The message will be taking, not the messenger. I also want to take the opportunity to say that I think everybody is intelligent, capable, and got up this morning to do the best that they possibly could. A part of this debriefing, we'll be talking about implicit bias. Really specific, we'll be talking about racial bias as it pertains to our case today. Knowing that implicit bias is an umbrella for a lot of terms, but we're just going to dig a little bit deeper into racial bias. I am not an expert at that topic, but I am stand before you as a Black woman with my own lived experiences, just as you are an expert for your own lived experiences. And I wanted to create this brave space where we can have some of these conversations. Is that okay with the team?
Yes.
Awesome. So tell me a little bit about how did it feel being in the sim? So not something that you did well or something that you wish you would have done after you were having your lunch, but how did it feel being in the simulation? A feeling.
It's an adrenaline rush.
Adrenaline rush, right? That happens in real life, especially clinically with this type of patient. How did it feel for anyone else on the team?
A little chaotic.
Chaotic. So love that. So that's real lived experience of chaos. All the things that's happening, all the things that need to happen in that emergency. How did it feel for you?
Like a battle between not being overwhelmed, which is like also indicative of like my practice, not being overwhelmed but trying to prioritize, right? So it was like, I feel like this, but I'm gonna do this instead because I need to take care of the patient.
Love that. Priority always comes up as we're taking care of these obstetrical emergent patients. And how did our partner feel in this emergency?
Yeah, I would say it's challenging, like trying to balance feeling because I have a child in my arm. I have my own response that I'm seeing, and I'm trying to make sure you're all right, trying to get information. So having to balance all of that at once is kind of like, and I had heard a comment that I was holding the baby a little too tight, but you know, it's just like in the flow of things, you're trying to focus in on everything at once. So it was a bit challenging.
Absolutely. I can understand that.
Yeah.
That is a normal feeling. But just to get everybody on the same page, Tiffany, what kind of patient was she? She was Afro-American. She was, what else? Power 5, so she was pregnant 5 times, had 5 babies. What's that?
39.
39 years old.
And she had a normal vaginal delivery. There was no complication.
She
So
didn't-
it wasn't expected, you know, that she, the placenta was intact, you know, we weren't expecting anything to happen to this sort of patient.
Love that. And some of that happened. So some of those indicators we included as what that high-risk patient might show up as, and then some of it was kind of a surprise to our team. So really quickly, what are some of the things that went well? What are some of the things that the team thought they did well with this case? Call for help.
So identifying an issue.
Early ID. What else?
Including the father.
Included dad. What else?
The verbal orders were like very clear. And believing the patient. That also was like really important.
Believing the patient. So I love that you said believing the patient. So many times this morning, the patient's voice came up as an issue for some of the missteps in our birthing spaces. When they looked at some data from the Department of Health, they actually found 3 themes that emerged. One of the themes was being heard and being seen in the birthing space, which included being believed. The second theme was consent. And the third theme was being included in their care. So as your team takes a minute to think about how eloquently you put it, believing the patient, what are some of the mitigation strategies that you might be able to use in your healthcare setting to make sure that every voice is heard in this type of emergency?
A line that I use is like, if you feel anything weird at all or just not like yourself, let me know. And then I also give them reassurance when everything seems normal, and like kind of giving like a definition of what it would be like if it wasn't normal. So like even with the hemorrhage, I will say the whole like if you're soaking your pad within an hour, or if you like feel a gush. And sometimes they can overdo it then, and they're like calling me, oh, I felt something every second, but I would rather that than the opposite. So kind of giving them the identifier so that they're feeling what's happening with their body and knowing that they can tell me.
Love this. This kind of double clicks a little bit on a question that came up earlier, right? As providers in health, what are we saying to patients to make them be heard? What are the key things they need to say to us in order to be heard in this space, right? Because it's more about empowering someone to speak up. It's also about having someone listen on the other end. So I love that you give some instructions about what normal looks like so that they can address what maybe things that out of the regular realm might look like. Love that. Any other strategies for making sure our birthing patient gets heard in this space that you think of?
Well, I always let patients know, like, I'm not gonna know what you're feeling. If you don't tell me what you're feeling, I'm not gonna know. I can just see, your blood pressure, these are things I see. There are certain things that you'll feel, you're the only one that's gonna feel it, Like with pushing, sometimes patients have pressure, but they just think it's normal. You let the patient know, if you have pressure, let me know. I have to make sure, like, the baby's not coming out. Like, you're not gonna be in the room and the baby's just gonna fly out, because some babies come out really quick. So you let them know, you tell me, I'm gonna advocate for you as well. So you may tell me something, don't be afraid that, no one's gonna believe you, because if you feel like no one's gonna believe you, I'm there, I'm gonna speak up for you. As long as I'm on the shift, I will speak up for you.
Love that. Master.
A lot of what we talked about earlier has to do with the patient being able to advocate for themselves as well. And the Bill of Rights was something that we brought up earlier on in the conversation. I feel like that should be something that happens once the patient reaches the hospital, right? So these, OBGYNs or whoever's caring for that patient prior to their labor and delivery moment, they're in a practice somewhere, they're in a clinic visiting this person every so often or whenever they have an appointment. I feel like a lot of what needs to happen is education before they reach that point where they're in the situation to advocate for themselves. Because we practice makes perfect, right? Mm-hmm. So they have to understand that before they actually get into that environment where they're having to do it. So.
Also just making sure that the support people feel comfortable speaking up to. Because maybe the partner is not completely incapacitated, but maybe they're in a lot of pain, or they're feeling dizzy like you were saying, or they're feeling a lot of pain so they can't speak for themselves. So maybe the support people like the partner or the mother or whoever else is in the room can talk for the patient.
Love that. That's a great summary. Those included things that you can do at an individual level, things that also might happen with policies and procedures. And I also saw someone had a checklist when you think of structural things that might help support to treat everyone the same when they come in our spaces. Love that. Something else that you guys didn't bring up that went well is early vital signs. So I heard them called for really early and each of their changes. That also was identified earlier in our talk. Anything else? Was there something that stood out that went well that wasn't addressed here for our onlookers?
I saw someone speaking directly to the patient.
Communication with the patient. Love that. Anything else?
Maintaining like a professional tone and like a calm demeanor.
Calm, professional tone. Love that. It's really difficult for that to happen in an emergency. So before we switch gears, let's talk about if you were to do this again, what might you do a little differently? If you wanted to move to make your 1% better.
I think usually in a simulation, I feel like I know the team. We do simulations in the hospital, we just like know the team, so we kind of like know how, and everything's done at one time, so it's kind of a little bit easier. But that's just kind of the way that, this this particular simulation is set up, so it's a little bit different.
Love that. Know the team, being familiar with the team.
Yeah, so it's a little bit
So
different.
one of the things is there were two nurses, the
Yeah.
primary and the secondary. So sometimes we'd be doing the same thing.
Yeah.
You know.
So I like that. So how do we prevent that from happening real life clinically?
Callback system and the feedback, yeah.
Delegation.
Some type of delegation, call back, close the loop, what has
Yeah.
been done, shouting that out and making sure the
Yeah.
person heard and identifies what has happened. Love that. What else if you were to make this better?
I think like actually having SBAR so that when they came in,
Yeah,
I
SBAR.
said like this patient had her child at this time, this is the blood loss, because a lot of the time is always like what has already been given, what has already happened.
Yeah.
And so I think that's something, and then also actually like measuring the amount of bleeding,
Yeah.
because at some point
Yeah.
I was like, it's 1,000, but I don't even know.
Yeah, because I was like, what's the EBL? Like, 'cause they were saying with the delivery, I was like, what's the EBL for the when she first came in? I was like, I don't know. And then you were saying something about like Methogen and like, does she have asthma? Or,
So, yeah, I
or
asked,
like
yeah.
hemodynamic, you're saying hemodynamic, I'm like, does she have asthma?
Yeah.
So love that. So a lot came up in this mini discussion really quickly. So they asked about SBAR. SBAR is a way that we communicate in healthcare that lets everyone in the room know what has happened with the background, what we actually see right now, what our recommendations are. QBL, quantitative blood loss, that is the gold standard for measuring how much blood loss that has happened. And on our plus side, I also heard about considerations for medication. So they did ask if I had asthma.
And
Yes,
hypertension.
hypertension.
Yeah,
before we
and
gave
other
the
just medical
Methogen.
problems. Yeah, for the before we gave Methogen and stuff like that.
So those are contraindications for some of the medications that we might give our patients for sleeping. So I know that we're creeping up with our time. Any lessons learned or takeaways from this simulation or this discussion? Anything you want to think a little bit more about or you want to add to your clinical toolkit as you move on from this simulation?
I don't know, it's always hard for me as like the primary provider to try to address the patient, but also address the support people in the room too, because I'm trying to save the patient, but also try to calm down the support people, because it's scary for them, I understand that. But also, you know, I'm trying to make sure that this patient gets moved to the operating room in the fastest, you know, expedited way too. So there's always a balance there.
So love that vulnerability. She specifically said, how do I balance communicating with the patient, the family member, and take care of this patient, right? Doing it all at one time. What are some ideas that might help out with that, or that you use in your institution?
Along that, just delegating, right? So deciding when we go in the room, because even with emergencies, it's so many people in the room.
Yeah.
If one person, some people are really not doing anything. So if you ask one person to talk to the partner, then that can help out.
Love that. Super important. A lot of these facilities have an OB call of some sort, an OB stat. For some facilities, the person that's on that call is a social worker or an admin person that they actually delegate that role to talking to the family member and to the patient.
And to add to that, that was good on the communication, because when she said OR initially, I don't work in healthcare, so I never really heard that term. And then she later explained like operating room, like, so I was like, okay, now I know where my wife is going.
Yeah, I forget that like people don't understand abbreviations. I'm like, I'm gonna do blah 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 blah
Yeah, I'm
blah,
like-
and I forget like people don't understand what I'm saying. So then I have to like say things in like layman's terms, and I forget that like I need to just say this in like clear cut language.
To your defense too, it's like you're trying to do things so quickly because time
Is
matters.
of the
Yeah,
essence.
so it's like.
But love that you brought that up, because it's not just what you do and what you say, it's how you do and how you say, right? Love it.
There's only one thing that I think about when we have a situation like that. I get the baby to a safe place, definitely not in his arms, in a bassinet, in a nursery, or, you know, where the baby can be cared for without all this confusion around. Because him holding the baby in his arms, that baby looks
But does he feel
But
like
that
the
was one of the
baby's being,
things.
but does he feel like the baby's being ripped out of his arms with his wife also being taken away
That
from
too
him
is
too?
a consideration, but he would have to be at least seated or
But I
something.
sat him down.
So this is a great conversation, right? Only because what happens, right? I think you
They
have
pass
to play
out.
by ear because it depends. The support person could pass out.
Yeah.
He expressed squeezing the baby as all of this was happening, right? Is the baby safe, right? And you're gonna have to play it by ear. American Heart Association also says, in a lot of literature, that when you escort that person, that support person out of the room during an emergency, they don't know what's happening in that room.
Not him, just the baby.
Yes. But we gotta think about him, right? Because he's super important in this particular situation. So sometimes a lot of literature just supports taking the person to a side where they might not be able to see all the blood, but maybe a corner in the room, just as this young lady stated, having them take a seat, assessing, do I need to take this baby away at this time? There's no blanket answer for it. Every situation is going to be different, and you're just going to have to play it by ear and see what's the most important focus for the safety of the baby. Love that. Any more takeaways before we close out for the group? Anything else you found that was important or that you want to think a little bit more about and include? We had a lot of things for change for next time. Know the team, more than 2 nurses, SBAR, QBL. What happens with our baby?
Yeah.
What happens with dad, right? So thank you so much for participating in today's simulation and debriefing experience.
Thank you.
Did you guys want the table back in front? Yes.
Jamila, can you hear us?
Can you hear us?
Oh, the hell is that? So we can hear. Jamila, we can hear you. Yes. Just make sure you invite yourself.
So I'm gonna ask Mrs. Charlene McGee to come up, Mrs. Monique Brown Mercado to come up, and we also have Miss Amanda Biasis. Did I say it right? Yes. And we also have Jamila Jackson, who's on Zoom. She is a mom of twins. So, yeah, to make everything work. Let's introduce her.
At this time, we also asked for everyone else to just start brainstorming questions.
So we're just gonna have everybody introduce themselves as well as give us a brief on their experience with maternal health. We're gonna start with Jamila, as she's typing kids, so we're gonna let you go. Jamila, do you mind introducing yourself and giving us a little background on your maternal health experience?
Yes, hi, my name is Jamila Jackson. I'm 40 years old. I'm from New York City, metro area, working 2 days back. And my experience that I developed peripartum cardiomyopathy. I became pregnant at 39 years old and discovered I was having twins. During my whole entire pregnancy, my blood pressure was very low. It was elevated. It was no more than 115, 120 below. During April of last year, this time, because my daughters, they were born getting 4th of 2021, and my due date was originally August of 2021. I had a doctor's appointment with my high-risk doctor because, of course, they said I was high-risk because I'm African-American, and I'm 39, and I'm having multiple. So, at my last high-risk doctor's clinical appointment with Dr. Moretti, which is one of the high-risk doctors at the hospital, I told them that I wasn't feeling well, like I felt poor. I noticed that I started developing, swelling in my hand and in my feet, and in my, I would say, my lower leg area was starting to swell really bad. And of course, he brushed it off and he said, oh, this is a part of pregnancy, you're not just carrying for one, you're carrying for two. But I explained to him about, I'm having like really shortness of breath. Once again, we attribute to just having multiple. 2.5 weeks before my very scary emergency C-section, I contacted Dr. Moretti via email and let him know that I just did a blood pressure check on myself. It was 140, which was something that I did not have my whole entire pregnancy. Up until this day, Dr. Moretti has not emailed me back. So now we're going to fast forward to May 4th. On the day of May 4th, the weekend before May 4th, I was having extreme shortness of breath. And then the night of May 3rd, it was to the point that I couldn't even lay down because I felt like I was drowning in water. So what I'm going to do is I'm going to tell you peripartum cardiomyopathy is a weakness of the heart muscle, which usually begins in the final month of pregnancy up until 5 or 6 months postpartum after pregnancy. On May 4th, I just made 7 months. So I had 2 doctor's appointments on May 4th, and I went to the hospital, and I got up early that morning because my doctor's appointments were until like 11 or 12 o'clock. And when I went to the emergency room, I went through it at 7 o'clock in the morning because something just was really, really off with me. It was to the point that I could take my finger and press my thigh, and my finger was making such indent in my thigh. Come to find out later on, it was fluid that was building up in my lungs. So my body was retaining, starting to retain a lot of fluid. So when I went into the emergency room, of course, they took me, to maternal right away. And that's when they saw that my blood pressure was just a little elevated at the time. By the time my family family and everyone got there a little later in the early afternoon. After they had did a lot of tests, they just were going to keep me overnight because they felt that I might, be experiencing high blood pressure. But then the test came back that I had fluid in my lungs that was going to that was actually going towards my heart. And I had to have an emergency infection. So imagine, this is my first time having children. There are doctors just rushing in the room, rushing all over me, nurses. I'm just being pulled so many different types of ways. My family is fighting. Thank God the other private doctor was African American, Dr. Kenny, and he was the one who recognized that I had pericardial cardiomyopathy because pericardium is something that is very misdiagnosed by a lot of OBGYNs during pregnancy because they just usually attribute the symptom to just pregnancy symptoms, swelling. They don't really make a big deal out of it. Long story short, I had to be totally sedated, knocked out cold, because all my vitals were crashing. My daughter was born, of course, premature at 7 months. I had one child born at 1 pound, 3 ounces, and the other child was born at 2 pounds. So now, this is my first time being pregnant. I don't even know what happened to me, because they didn't even, to be honest with you guys, they didn't even tell me what was going on. All I knew is that when one particular test came back, everybody just started freaking out, everybody started going crazy, until Dr. Clooney came in and calmed, the scene down because it was very chaotic. I was in ICU for about a week and a half, and then I was moved to the cardiology floor. And that's when I started saying, what happened to me? Because still, I never knew what happened to me. And that's when Dr. Clooney came into my room and explained to me what happened. So at the time of me having an emergency C-section, my heart fraction was only at 40%. When you have a good heart fraction for a woman, it's anywhere between 50 to 74%. Mine was at a 40. And when I came back to get an echo in August, it only went to 45. Thank God I didn't have to go home with a pacemaker or a heart life vest, but I am on medication. So the survival rate for women is about half of the women will recover completely, and then the other half won't recover at all, and then you have the percentage of fatality. And African American women, this is the shocking thing that I found out, African American women are likely to be diagnosed twice likely to be diagnosed with PPCM compared to Caucasian women. And other risk factors always take into play that age, and also if you're having multiple. I also found out that African American women are twice likely to recover. Their recovery will be longer, or they will not recover at all. So if doctors will do the BNP test, which is a blood test that will measure the proteins that are made in your heart and blood vessels, if they would discover that it's high, then it will let them know that heart failure is taking place. But BNP test is not ordered in any of the pregnancy tests that we have to do, such as the glucose levels and, testing for, I want to say historically, I think it's anatomic fluid, to make sure, the child is not presenting any Down syndrome. The BNP test is not one of the tests that are included. And it's something that I'm advocating for and I'm fighting for, because I suffered with depression, of course, at first, because I'm a first-time mom. My children are in the NICU fighting for their lives. One of my daughters came home in July, and the other one did not come home until almost November. And she had developed premature lung disease, and she has to come home on, I believe, Give me 1 second. This is the oxygen tank that she has to come home on. And this is the oxygen tank that is used in the house. And as a new mom, that's another thing that they do. They throw these things at you that you have to come home and you have to do on your own, which is very, very scary. So, I'm very grateful to have been, brought on this panel to speak about my experience. And I want people to take pericardial cardiomyopathy very serious as you are looking into your patients, because a lot of times, as I said, the symptoms are just pregnancy symptoms. But when you start hearing she's having very bad shortness of breath, and she starts saying that when she lays down, she's feeling like she's drowning, please, alert a doctor to all the nurses. Please alert one of the head doctors and let them know that you think that this is something that the patient might be going through at this time. I had my experience was very traumatic, of course, but being that I'm living, I'm not going to live in vain. I'm advocating, and I'm starting a nonprofit organization called P.S. Mommy Loves You, to help all the families that have lost their loved ones due to some terrible death, to help the families get counseling, and to help the children that have lost their moms, that have never met their moms, to help them, with scholastic needs, early intervention, just different things that the children need, because most of the time when this happens, the child is born premature. And in my study, I have found out that a lot of women, especially one named Lacey Cole, she's from Alabama, she died 2 years later from having pericardial cardiomyopathy. Her daughter had just turned 2, and probably 2 weeks later, her husband found her that she had transitioned in her sleep. So I just want everyone to take it, very seriously. And if there are any questions anybody would like to ask me.
No questions as of yet, Geneva, but thank you so much. We're going to hear out everyone else's experience. Ms. Brown Mercado, would you like to introduce yourself and speak on your experience as well?
Sure. So before I introduce myself, I just have to say to Jamila, Jamila, I'm so blessed and honored to meet you and your family and your journey. You will be in my thoughts and prayers for your strength, because no mother should have to, no parent should have to go through what you've been through, and you've just touched my heart. So hello, everyone. My name is Monique Brown Mercado. You can call me Mo. My friends call me Mo. So my journey, I now have a beautiful 8-year-old son, but my road to having him was very complicated. So for 5 years of trying to have him, I had 10 miscarriages. Well, actually more than 10 miscarriages. I actually stopped counting after 10. Many of them were around the 3-4th month, and there were no real reasons given to me where I understood what was causing those miscarriages. It was to a point when I felt like, here I am, someone who pretty much who has found success in a lot of things and can articulate and understand a lot of things, but I just couldn't understand this. So I think after my second miscarriage, my brain just couldn't retain what was happening. So I had an advocate in my husband who said, you know what, I'm part of this journey too, and I need to be part of being in the hospital, asking those questions, and being your voice, because you can't absorb what's happening. So during that journey, we received a lot of pushback because my husband wanted to be a part of it, and because he was asking the questions and I was silent. Because he said my job was to try to have the baby, it's his job to understand it and to articulate it to me in a way that I could understand it. So he got a lot of pushback, and we ended up going to many different doctors as a result of it, because we felt like this is a team effort, and if he can't be a part of it, then you shouldn't be treating me. So we found that right doctor, and happily, I got pregnant, but during that pregnancy, I did not connect with my son because I just knew in the back of my mind it was going to end up in a miscarriage. So I gained 75 pounds. I went from net size 8 shoe to a 10.5. I had a C-section. My husband was there during the section, and he saw everything. And after I had him, I got home and I suffered from really bad postpartum, from having seizures to not being able to lift my child because my child was 10 pounds at birth. And so, when you have a C-section, they tell you to not lift anything heavy. So my son was 10 pounds, so I couldn't really lift him. All they could do was just put him on me. And he wasn't even taking breastfeeding. That was a challenge for us as well. So I suffered from really bad miscarriages really bad postpartum with not being able to connect with him, having seizures, and just being afraid to be by myself. I felt like a failure for a while. And then just having that support, because I think many of us feel like we can't really talk about it because we're supposed to be strong, because you don't hear a lot about, other people going through this journey. So I think it's amazing that you have something like this where someone like myself who's not in the nursing industry can understand it. And I wish I had that. And my goal after this is to share with as many young women as possible about what their rights are and feeling comfortable asking those questions.
Thank you so much. Amanda?
Hi, my name is Amanda Thompson. Just listening to everybody, I had to sit back and reflect of two different situations that I had encountered. My first situation, I was pregnant, I believe it was in my 20s, 27, 28, and I had an ectopic pregnancy. In this particular clinic that I went to, I've been going to this clinic for a long time, got pregnant. And just correct me if I'm wrong, nurses. I know usually when you get pregnant, your levels go up as far as your blood. So got pregnant, and the nurse, Caucasian nurse, I explained to her, something is wrong. And I'm very vocal when it comes to things. With my body, when I know exactly something is wrong, I'm going to vocalize it. Pregnant, I stated to her, something doesn't feel right. She said, no, you're fine. These, you're going to go through these things. You're going to feel weird because you're pregnant. I said, no, something does not feel right. She said, you're fine. Okay, the next day, called my mother and I said, I don't know, but I don't feel right. We went to Brooklyn Hospital, and come to find out I had an ectopic pregnancy. It was in the tubes, and I had to go, I had to go to Maimonides because now I had to take an injection to get the baby out. Now, if I didn't vocalize and constantly and told my mother, something is wrong, it would have erupted. So when you guys speak about being vocal is very important. And I'm lucky to have a best friend, Dr. Johnson, as a nurse, because he also stated, make sure you're vocal when you go into the doctor, especially being pregnant. That was my first experience. After that experience, I stated, I can't go to this clinic because I didn't like the way the nurse just brushed it off and said, it's okay, you're fine. You're gonna experience different situations. You're okay. Don't worry about that. That was my first experience. My second experience, which was it was totally different. Got pregnant. And I suffer from fibroids. I have a lot of fibroids. And in my journey, I wasn't trying to get pregnant. Speaking to my new doctor, I stated to him, I have these fibroids. What can I do? He said, if it's not bothering, don't touch them. Okay, we're not gonna remove them if they're not bothering you. Okay, if you wanna get pregnant, let's see what happens. If you're having issues with getting pregnant, then we'll try to go into it more to figure out what's going on. Got pregnant. Prior to me being pregnant, I always had minor issues, but nothing to the point where I needed them to remove them. Got pregnant, the pregnancy was going well, but it was in the middle of the pandemic. I got pregnant. So now I'm dealing with the pandemic, this new situation, and not being able to have my first baby the way you imagine. Like, oh, you're pregnant, you can go out, take pictures, enjoy. We couldn't do that because of the pandemic. So now I'm dealing with that mentally, and then trying to process, being pregnant. And then, of course, watching the news and hearing that you have mothers dying off of, being pregnant and not getting the right health benefits for them. Okay, got pregnant in around 23 to 25 weeks, which the scenario that you guys performed really took me back. 23 to 25 weeks. I told my husband, something is wrong. Like, my back felt, I can't even explain the way I was feeling. I could not, I was kneeled over, like something is wrong, we have to go to the doctor. We have to go to the hospital. Went to the hospital, and we in the hospital room, in the emergency room, and they're checking to see what's going on. At that point, everything was fine. They were monitoring me. So we're in the hospital bed, and I remember this as day. In the hospital bed, we're watching, I think it was Seinfeld on the TV, and they're monitoring me because obviously they can see everything that's happening from outside. All I know, it was like 10 nurses that stormed in. And when they stormed in, they're like, okay, let's move her, and then we're like, what happened? What's going on? And tears are coming down my eyes because no one is really saying what's going on. All I know, there was a head doctor, I cannot even remember her name, a black doctor, and she said, I am not delivering a baby at 23 weeks. So you guys, we're going to do whatever it is to make sure we don't deliver at 23 weeks. We really didn't understand what happened because they didn't really say. In my mind, I thought it was the fibroids. I think the fibroids were fighting with the baby, trying to figure out who deserves to be in here. I don't know what was happening. But past that, everything went well. They didn't really explain and I honestly feel like they didn't really know what went wrong. But she stressed, and I really appreciate that doctor who said, I'm not delivering a baby at 23 weeks. That was that scenario. My son was supposed to be born September 2nd. You constantly go to your checkups. The first week in August, went to my checkup, just a regular checkup to make sure everything is going good. They were monitoring me to check his heart. His heart sounded a little all over the place. It was irregular. And my doctor, Indian doctor, he stated, okay, let's keep you monitored just to see what's going on because I don't like the way this sounds. Okay, fine. Kept me there. My husband was downstairs, and he's like, what's taking so long? I'm like, I don't know. They just have me in the monitor trying to figure out what's going on with his heart. He said, okay, fine. I want you to come back tomorrow, the next day. Went to his other clinic in Queens, and they set me up again, monitoring, checking. The same thing happened. He said, this doesn't sound right. I don't understand why his heart rhythm doesn't sit right with me. I'm rushing you to the hospital, Long Island Jewish. He said, can you get there by yourself, or do you need me to bring you, get the ER? I said, no, I'll drive. I called my husband, and I told him that you have to meet me at the hospital. At the hospital, now they're checking the same thing, monitoring me, trying to figure out what's going on. The nurse comes to me. I'm laying in the bed. The nurse is checking me. I'm falling asleep. she's monitoring me, she comes back in. She's like, you have to flip. Turn this way. Turn this way. They couldn't hear his heart rate. So now at this point, I'm losing my mind because it's like, I'm laying down sleeping. I can hear the monitor going, I'm like, okay, he's fine. Fell asleep. And she rushed in and said, we have to flip you around. You have to turn. You have to do this real quick because we cannot find his heartbeat. Now, again, we're in the middle of a pandemic. I'm in there by myself. My husband is on his way. And, they're trying to figure out what's going on. So at this point, my doctor, which I already stressed to him, I said, I don't care what you're going to do. You are the doctor that's going to deliver my baby. We've been going through this process for the longest. You are supposed to be here. Don't bring me anybody else because you know the steps. So he said, don't worry. But I knew something was wrong because he turned pink. He turned pink and he's like, listen, I know you want to deliver naturally, but we're going to have to cut you because his heart rate, they couldn't understand why his heart rate was dropping. And I said, you know what, at this point, I didn't want to have a C-section. I said, do what you have to do because if we don't understand why his heart rate is doing this, just cut me at this point. And mind you, at this point, I believe I was like 6 centimeters, right? Or something like that, Marcus, 6 centimeters. And I really was stressing, like, I really want to push. But I said, at this point, the way he looked, my doctor, I said, listen, just take him out because I don't know what the issue is. Take him out. And thank God he came out August 8th, which he was supposed to be here September 2nd, came out August 8th. He was healthy, thank God. But once he opened me, he said, you have a lot of fibroids in here. So my assumption, I thought that it was definitely the fibroids trying to be the main purpose. Like, no, little boy, who are you? I've been here for so long, you got to get out. And, I really want to say that, they have a lot of nurses who are very vocal and will be your advocate and say, no, this is what we're going to do. This is not what you're going to do. This is the path that we need to do for you. So there's a lot of nurses who are out there. One thing I do want to say that I did have an issue with, when it comes to breastfeeding, I had a big issue when they brought someone in to first-time mom teach you how to breastfeed. It was a Caucasian, I believe a Russian lady who came and she just, this is what you have to do. And I was like, wait a minute, like, first of all, I don't know, this is new to me. I feel like you have to be sensitive because you don't know what's happening. You're a first-time mom. I don't know what I'm supposed to do. And she was like, no, you have to do it this way. And I was just like, okay, so yeah, like, so that was my experience as a first-time mom.
Charlene?
Hi, everyone. My name is Charlene McGee, and I am the aunt of Denise Williams. I don't know if many of you heard her story, but last year, August the 28th, before August the 28th, she gave birth to a little girl, Adelie, 7/11/2021. She also had a 3-year-old little girl, and she was suffering from postpartum depression. And she was complaining to her mother about her symptoms and how she was feeling. So my sister Linda, she basically called the ambulance on August the 28th to have Denise evaluated for postpartum depression. The ambulance came on that day. Denise requested to go to Long Island Jewish. However, the ambulance took her to Queens Hospital. On August the 29th, my sister received a phone call from a physician stating that Denise will be released from the hospital that Monday on August the 30th. On August the 30th, 6 o'clock in the morning, my sister received a phone call, which she missed, and at 10 o'clock in the morning, she received a phone call from the coroner's office telling my sister that Denise's autopsy will be held on Tuesday. Now listen, she received a call from the coroner's office. She didn't even understand what they were saying. She has her own health problems, so my sister Linda thought that her doctor was telling her that she was going to get a biopsy. So she's confused. She doesn't know what is happening. At 1 o'clock that afternoon, the time span, from 1 o'clock, she received a phone call from the physician, telling my sister that Denise is dead. Not that your daughter passed away, that she was dead. My sister was going crazy. Denise is, she has 10 siblings. So of course everyone is, trying to understand, what's happening. She goes to Queens Hospital. No one is giving my sister any answers. I was in North Carolina at this time, and I flew back, and I told my sister, and I told my family, I said, when I get back and my feet hit that ground, I want y'all to meet me at Queens Hospital. We got there at Queens Hospital that day, August the 30th. We were there at 8 o'clock that night, 8 o'clock that evening. I went live on Facebook. I have a lot of friends. I'm a part of a wonderful sorority. And I went live, and I was pleading and requesting every politician that I ever worked with, every city council, every assembly person. I was screaming, like, help my family, because my sister wasn't getting any answers. And it took about, till this day, to be quite honest, Queens Hospital hasn't said anything about what happened to my niece. As a result of everything, that's happening, wonderful people have stood with my family. We had rallies on behalf of Denise, bringing awareness to her passing. So myself and my family, we started a nonprofit, a foundation called Niecy's Purple Heart Foundation, because my sister couldn't even sue the hospital. She couldn't sue the hospital because they're saying that Denise died from a pulmonary embolism, and she was obese. I think that's just like the go-to result, but my niece left behind 2 babies. So we have to figure out how these children are going to be cared for. My niece Belinda and her husband Stanley, they are the primary caregivers for the girls. The girls are with me. I have a daycare, so I take care of the girls during the day. So I'm the spokesperson for my family. I sit before you all today and tell you that it is the most devastating thing to witness your sister lose hope in the system. My sister, Linda, completely has no trust in the medical system at all. I'm here as an advocate for my sister. I'm here as an advocate for my 2 little nieces. I'm an advocate for everybody in my family. And I have 3 things, right, that I would love for you all to do, right? It's the call to action. So first, if you want to donate to Niecy's Purple Heart Foundation, that's wonderful. The second thing that I would like for you all to do, if you have not heard of the New York Health Act, right? Look it up. It's literally, the act is for every New Yorker to have health insurance, whether you're immigrant status. Contact your local senator or your state senator, and you request that they pass this bill. Niecy's Purple Heart Foundation, we stand by this bill. This is something that's going to help every New Yorker because Denise had Metro Plus, and with Metro Plus, HMO, she can only go to City Hospital. She can only go to Jamaica Hospital, or she can only go to Queens Hospital. That needs to change. You should be able to go to whatever doctor you want, whatever hospital that you choose to go to. So please, please, I am like, this is really, I'm an educator, right? I teach babies. I care for babies. I am now a maternal health advocate. I just got my certification to become a doula. And my family, we are continuing to fight for Denise. Like Denise is, her name and her life is not gonna go in vain. So I would appreciate, if you want to follow us on Instagram, it's Niecy's Purple Heart Foundation. On Twitter, it's Niecy's Purple Heart Foundation. Facebook is Niecy's Purple Heart Foundation. If you want to get more involved, you can click the link on Linktree, and there's a code where you can fill out the information and help us. And we really appreciate you. Thank you, Dr. Camilla, for inviting us, and I'm so grateful to be here to meet everyone. Jamila, like her story is just phenomenal, and I'm so sorry that she has to go through that. But if anyone wants to connect with us, please feel free. I have my notepad. I will take your information down, and we can exchange and network with one another.
Absolutely.
I actually reposted her story on my Instagram because I follow for Kira's mom.
Yes.
And the thing is that I've been following for Kira's mom way before I became pregnant because I became an advocate in Shaika, Washington situation. I had become friends with Shaika's partner who was left behind, which is her daughter Chloe. And the thing I just want to say to everybody, and what I'm going to say real quick pertaining to my story, is of course the most difficult thing is becoming a NICU mom. And I want the nurses and the doctors that are in attendance, or soon-to-be nurses, that might be doing their residency, and doctors to understand that NICU mom is a lot that we go through. The first time I was able to see my daughter was on Mother's Day, because I had her May 4th. I wasn't allowed to see them until Mother's Day, and the first time I walked into the NICU, I was strolling through the NICU in a wheelchair, I'll make you laugh. It looked like I was on Night on Elm Street, Freddy Krueger's basement. It was like that, oh my God, it was bells ringing everywhere, because they have a monitor attached to each child. So every time their heart rate drops or their breathing, this monitor is going off, goes off, goes off. As you can hear, one of my daughters is yelling. But becoming a NICU mom was such a traumatic blessing for me. And I want to tell each and every black lady that's on the panel that your story is a traumatic blessing. You are now able to advocate because God has given you a testimony to save others. Even though we might have been thrown on the line as a sacrificial lamb, but it's a reason why, and we cannot go in vain. To Denise's family, like I said, I followed the story from the beginning. I was going to come to Queens Hospital when they did a rally, but my other daughter was still in the hospital. She had to get a blood transfusion, so I wasn't able to make it. But I want to tell you that your strength is everything. And when people hear my story about how you were 27 weeks, I let people know, do not feel sorry for me. My story is traumatically beautiful. I wanted to make you every day. I remember when they told me that my daughter that had the me, they told me, put me in a conference room one day with every doctor that probably was in the hospital, every nurse was in there and told me And that day, I prayed so hard and I cried so hard that I don't even remember the prayer. But what I do remember, when I got off of that incubator, I told everyone there that I am leaving with both children, not just with one. And that's exactly what I did. So please know that you are phenomenal. Please know that your story is something that needs to be shared. I am a proud NICU mom. I have even started an activist group in Brooklyn Hospital for NICU moms. And they call me up to this day when any new mom enters and she's having a difficult time, it's very difficult for coming to NICU parents. It's not easy, you know. Even me and my child's father, who is phenomenal, but we went through a very hard transition. He is NICU parent, he is. And we're still having a hard transition as well because it's very traumatic for him because he wasn't even able to be led into the C-section room because I was knocked out, you know, entirely. So he goes through his own, depression as well. So your mates will go through depression as well. But, you know, if you guys want to take my information, I will give you my email if you guys want to write it down. You can JJ. It is JJATKSON0923@gmail.com. And please reach out to me. I would love to speak to you, and please maybe you can help me start my nonprofit organization because I don't know how to start. You know, I want to do PS Mommy Loves You, but I don't know where to start at, so I would like to be educated on it. And thank you so much for having me. And would y'all like to pick the girls real quick?
Show us those babies.
Look at him. Oh, she's so cute.
Oh.
My fighter, my warrior. Alana, you know, you like to say hi.
Oh my God.
Does anyone have any questions for the panelists?
I have a question for Amanda. My name's Amanda too, by the way.
Hi.
I wanted to know if, like, before you were expecting, did you ever have a doctor tell you that you had fibroids, and did they make a plan to get rid of them?
The first clinic that I went to, the one that I left, she did tell me that I had fibroids, but she didn't really. I don't think they understand where it comes from because she really didn't tell me much. She didn't say if to get rid of them. I just had other people tell me don't get rid of them because sometimes they might just take too much off and you can't get pregnant. So we never had a plan. Never sat down and say, okay, this is what we're going to go through. All they kept saying is if they don't bother you, don't touch them. That's all they keep saying. Up to this day, I don't even know how I even have fibroids. Some doctors, my primary doctor said it's because we eat meat. Okay, I don't understand where that comes from. I mean, but from my current OB, he said I have a lot. Some while I was pregnant, he said some were the size of a tennis ball, So, but I just don't have. No one has given me the answer as to where they're coming from or what to do. Again, he stated, don't remove them if you want to have another baby. Just leave them there. That's all I get. I don't know too much. That's that.
Any other questions?
Well, I have one quick question regarding everyone's mental health. Do you still deal with mental health issues now, even though it's been some time since the event or experience has happened? Are there still things that you deal with to this day that maybe, you suppress them, but sometimes something is said, or you see someone running with their child, or, anything of that nature, and it kind of like triggers you and it brings you back?
For me, yes. And my son, like I said, he's 8 years old. And so because I didn't have that connection with him early on, I sometimes deal with a lot of guilt because he'll ask me questions, or he has a tighter bond, I feel, like with his dad, because his dad was that nurturer in the beginning because I couldn't be there. I didn't have the emotion to be there for him. So sometimes I do deal with that, and I seek help for that, to try to not feel guilty for having postpartum. But yeah, it is what it is.
For me, when I think about trying to have, well, not trying, but wanting to have another baby, I think about, oh gosh, am I going to go through this again? That's one. When you guys just did the assimilation, right? That brought me back, because I told my husband, oh my God, that reminded me of that day. That brought me back. And I think one of the nurses, I don't see her here, she had said something as far as, when you have your mom. Typically, when I thought about being pregnant, I thought about, okay, I'm going to have my partner and my mom there. But in the process of having COVID, dealing with the pandemic, I couldn't have my mom there. Oh, it was you. Right. I couldn't have my mom there, even though my husband was definitely, he played a big role. Even though I know he was nervous, he made sure he stayed like, okay, I'm nervous, but I'm not going to show you that I'm nervous, but you still want to have your mom there, so it's very important. But, I just think back, like, dang, I hope that when that time comes, if, we have another one, that we don't go through this again. It's smooth sailing. So, yeah, sometimes I have little moments.
Well, for me, because I care for the kids on a daily basis, and my niece Belinda and I are very close. So when I pick up the girls in the morning, and I can say, Belinda, like, what's going on? She's like, Auntie, let me tell you what happened last night. Aviana was crying so bad for her mom, and she's like, oh, I want mommy. And so my niece we say mommy is in heaven, and she looks up, and say mommy's in heaven. So when we went to go clean out Denise's apartment, Denise had got them a teddy bear with literally, like, I believe it has a voice on it. And so the girls, the 3-year-old hugs it anytime she gets sad. But when she's with me during the day and she's doing dramatic play, she's on the phone and she's having conversations with her mother, and it's really just, I always get upset, I cry, I always call my niece or call my sister. And I had an experience, I went to the mall, I've never been to Build-A-Bear before. I've heard about Build-A-Bear. If you've never been to Build-A-Bear, if you going to Build-A-Bear for something emotional, trust me, you're going to be laid out on that floor crying. I was crying in Build-A-Bear because you get the heart, right? You get anything, the heart beating. And I got this beer for Aviana. She like Frozen, so dressed in the dark, the beer up, and you have this whole little ceremony. And I got songs that she liked, that her mother liked. It was just such an emotional time. I didn't think I was gonna be like that in Build-A-Bear, but but I was. And so like I said, it's like we go through it. Like, it's not every day, but if she hear other kids talking about their parents, and she wants to talk about her mom, and it's sad.
Anybody else have any questions before we close out our community?
I just want to talk about what support you received after your experience from your healthcare team.
From the healthcare?
After your experience.
Well, my doctor was actually very good. I commend him because he was fast. Like I stated, when it happened, he turned another color. That's how I knew something was wrong. And his team was very prompt. They didn't wait. And they ran on him. Whatever he said went. So they didn't, okay, no, but we don't, who's the doctor? Dr. Nanda? Okay, yeah, let's do it. Because they knew of his role and how good of a doctor he was. So I think in my case, he handled it and his team handled it very well. So I'm kind of happy that I had him. So they did a good job in that aspect.
For me, I had a really great team of people who supported my entire family. I think I said right after I had my son, I had the seizures. And so they really over-communicated everything. And they spent a lot of time. I know we talk a lot about the moms, but I think it's important to talk about the dads as well. And so my doctors really were so close to my husband, so that we all knew what was going on, and he knew what to expect before it even happened. So he was able to help me when I wasn't at the hospital or at the doctor. And if he had questions, he had a number that he could talk to help coach me through the next phases. So, I mean, I can't complain. But I'm part of that one and done crew. I can't even imagine going through it again.
Well, as far as my family, I wouldn't say doctors, but people, organizations in the maternal health world have really been there for my family. Bruce McIntyre, Amber Rose's partner, I call her Dr. Shawnee Gibson. I love her so much. If y'all do not know this woman, my God, she is phenomenal. She is definitely her sister's keeper. She did a group therapy session with my family. It was awesome, and we're still connected to this day. Also, Amari is phenomenal as well, and Charles Johnson also for Kiera for Moms. He's a good contact person that's been there for my family as well.
Can I just piggyback on what you said? As women, we get a lot of support as far as postpartum, but like you stated, I feel like the men also deal with a lot, and you typically shut down. Because my husband, and I'm sorry I'm putting that out there, but he had his own little postpartum after, and he always says it like, we went through a lot, and I'm like, I went through a lot. But in talking to him, I understand they go through a lot also. So I feel like as women, we also need to also make sure the partner is doing well, because they go through something. They go through this, and they tend to stay quiet and not say anything. Of course, because the man is supposed to be tough. So we also need to make sure we also speak to the dads, because they are going through stuff and they're not saying it.
Yeah, I'll add to it. So I learned a lot about myself with the birth of my son, right? So I do have an older daughter. I was this gentleman during my first daughter's birth, almost throwing up, sitting on the floor, and the nurse had to sit me down. So I was like, oh my God, here we go again. So I lived that with you when you went through it. But I think communication is so key. The reason why I was so calm when with Dr. Nanda during Amanda's pregnancy was because when I was en route to the hospital and I got there, Amanda doesn't know this because she was taking out the room. So, we got in there, you hear the baby's heartbeat on the speaker, and and all of a sudden it just stopped. So we all got nervous, and they rushed her out the room. You know, Dr. Nani just changed his wardrobe, and he pulled me over to the side and looked me dead in my eye and shook my hand and said, I don't want you to worry, I don't want you to panic, this is what I'm about to do. And he told me everything he was gonna do to Amanda. And he said, he needs me just to keep that straight face, keep her encouraged, keep her going. Don't have a panic attack. You won't see me, but I'll be right in the room with you guys. But you know, during the C-section, they got all the curtains up. All I see is Amanda's face, and I'm holding her hand. And then, you know, they have the scale for the baby on the left-hand side. So as a man, you know, it's pride. We don't really show emotions, whatever, but trust me, we cry in the shower every day. Not everybody has the privilege to have AJ on speed dial to text him something or pick his brain about things. So if you do have a friend that's in the nursing field or that's a doctor, definitely express, you know, what you're going through, because it does help. Because trust me, I cry in the shower a lot. But, you know, just being there now and watching my son grow and all the things he's experiencing now, I mean, it's a blessing, it's a privilege. I always tell Amanda, listen, I thank God I'm a guy, because I don't know how y'all do the things that you guys do. I could not do it. So for mothers that are single, that have a father in the house, I don't know how y'all do it. I could not do it, but I'm very appreciative. And I do believe communication is key, even after the birth. I do believe there should be a program for fathers on how to be a support system, and also for young, you know, adults like all of us, or young adults trying to raise kids on our own, you know. So communication is so key. So that simulation you did with the nurse that was sitting my guy down over there, that was spot on.
I actually have a question though, since you brought up a good point about, you know, having support for the fathers. Does the state have any funding for fathers, like, you know, helping them through after having the child, how to support the child and also how to support your spouse after? Do you know anyone?
I don't think that this,
Not that I know of, but I do know that, you know, there are some organizations or folks that have started programs with dads are involved, but maybe that's the next business you guys want to start, or the next nonprofit, because it is important, it really is.
It is. Well, I think that Save a Rose Foundation, which is ran by Bruce McIntyre, who is Amber Rose's partner, I know they have something for dads.
Yeah, he came to one of our rallies and spoke.
Just a quick comment. A lot of times, some of the fathers, they don't know there is paternity leave. So when the mothers give birth, especially people that work, so I'm going to take 2 days off. And I say, you have paternity leave. We have so many resources, but we don't know how to tell the patients and their family members, this is what you have to, this is the right you have. Because they think they're going to lose their job by coming to the hospital and they will their father off, taking a few days off. There is paternity leave in the system.
Right.
We're not the best, we're not in Europe, we're in Switzerland. There's a little bit of something.
I actually have a question. So what do you think healthcare providers can do differently or should have done differently, and how can we make you comfortable, or would have made you more comfortable during your experience?
Well, for me, for the first experience that I had, I feel like the nurse was very insensitive.
Yes.
You know, the nurse was very insensitive. She stressed, like I stated, oh, you're fine, you're going to be okay. This is what you experienced. I feel like it's sensitivity training, if that's something. Sensitivity training on how to speak to the patient and to, you know, be able to pinpoint, like, okay, this is what they're saying, you know, just a guidance. That's very important. I'm an HR manager, so training is important. Training is important. Customer service, even though this is a hospital, customer service is very important, because I love to go into a hospital or speak to my doctor, my OB, and feel very comfortable, you know. So feeling comfortable speaking to your doctor is very important, and your nurse, the person at the front desk, because, you know, everybody ties into each other. Everybody ties into each other. So I feel like training is needed in that aspect.
I completely agree with you on that, because, you know, as you were talking, you know, I try to suppress a lot of things just so that I can manage the next thing. And I remember now the first miscarriage that I had, being on the table and the nurse saying, "Oh, you're miscarrying. You see that right there? That's the heartbeat. It's gonna get gray.
Wow.
And so go home and you'll pass it."
Wow.
And I was like, what? What does that mean? Don't worry, oftentimes the first pregnancy ends up in a miscarriage. You'll be fine with the next one. And I'm like, but wait a minute, I don't understand. What did I do wrong? And I walked away thinking I did something wrong. So I think there needs to be more education. Like there was a lot of technical terms being thrown at me. And I'm like, okay, I'm not in medicine. I don't know what that means. I need you to talk to me like I'm a 2-year-old. Help me understand this. And I didn't walk away feeling that.
I feel mandatory programs. I was from the GYN. I don't know about the hospital.
Mm-hmm.
But, as you do your visits monthly with your GYN, you should be forced to go to these programs to understand miscarriages. The process you go through during birth and everything. Like you should have to go through that so you can get a better understanding of what your body's going through and how to support yourself through that process.
I feel like the healthcare system should, basically force these hospitals and physicians to be transparent with families, and also they need to be held accountable for their misconduct. And I don't feel like they're being held accountable for what they're doing to women of color. It's almost like they're saying, "Oh well," and whatever. There's no accountability whatsoever. In any case that you hear, no one is being held accountable for these women who are passing away.
Yeah, that's true.
You experienced it and you know it best and you don't change it, who do you expect to change it? Right? So it's on all of us to do that. So I want to thank you all. Again, can I get all my committee members to come to the stage real quick? So we can get a quick picture. Also, please do not leave without doing the post survey on your way out. The barcode is right here. I will stand by the door to harass you before you leave. Thank you. All my committee members, absolutely. Taylor?
We definitely think that it's important to also have support as much as you can. Whether you have a family member that's a nurse, family member that's an OB provider, ask as many questions outside of the provider that you have, network, to as many people as you can. Sorry, I'm out of breath, but Poppy Seed Health is my doula company, and they offer a wide array of services. So they gave out tote bags, but you guys can look them up. They're featured on NBC, and they're a great doula company if anybody is interested or is looking for additional advocacy for childbirth. Feel free to take one on the way out. That's what it's.
So thank you all for attending, and whatever you hear, if you can share that with at least one person, and one person can share it with someone else, and that's how we can find ways to spread the word around about maternal health. I know we speak a lot about Black maternal health, but that doesn't mean it doesn't happen in other ethnicities. It's a lower number, but it still happens. So please share that story, share whatever facts you've heard, so it could be help us or help someone else not live their life or for them to live a better life, a better quality of life.